in the trenches. Today I'm going to talk about the antiphospholipid antibody syndrome. Saw a patient this morning who may have this. This is complicated and it's serious. Okay, you think about this, it can cause venous thrombosis. It can also cause arterial thrombosis. Recurrent pregnancy loss. And thrombocytopenia. Okay, and it could cause a combination of these. So a patient who has deep vein thrombosis and you don't know what causes it or what caused it, or if they have a thrombosis in an unusual location, splenic vein thrombosis, hepatic vein thrombosis, portal vein thrombosis, you have to check for this condition. Arterial thrombosis, stroke, especially in a young person with no cause, MI in a young person with no cause. You have to think of this. Recurrent miscarriages, a woman with 3 or more miscarriages, they need to be evaluated with this, and thrombocytopenia is usually associated with it. 50% of the time it's associated with a CT disorder, usually lupus. And 50% of the time not, just exists. And you could pick this up, and this does exist. So when you evaluate for this, okay, you're talking about 3 tests. So lupus anticoagulant screen, anticardiolipins, antibodies, and anti-beta 1 glycoprotein 2 antibodies. These are IgG, IgM, and IgA. Okay, lupus anticoagulant's a difficult test to get, especially if someone's anticoagulated, and it's better to get this before you start treatment. Sometimes this could present as an elevated PTT, and you have a factor inhibitor, and if you do a 1-to-1 mix, it won't dilute out. And they could use something called a Russell's viper venom dilution or a stay-clot, but this could be hard to diagnose. This is the most serious form, and this is the strongest association with venous thrombosis. Anticardiolipins and anti-glycoprotein, anti-beta 2 GP1 antibodies should also be checked, and you could actually have a patient who's triple positive. These are what you think of. Now, there's something called CAPS, catastrophic antiphospholipid antibody syndrome. I've seen this about 3 times in my career. This is really a thrombotic storm. The 3 things, you have microthrombosis here, whereas with regular antiphospholipid antibody, you have macrothrombosis. So you have 3 organs, systems involved, like acute kidney failure, bilateral adrenal insufficiency to bilateral adrenal thrombosis, ARDS, pulmonary infarction, or you get that's 3 organ systems. Okay, they have positive antibodies, and it occurs within 1 week. So this is rapid. And these people needed to be treated with IV heparin, steroids, and sometimes plasmapheresis. That's a syndrome. It's also known as Ashman syndrome. When you diagnose this, you need to treat them, and they need indefinite treatment. And this is one indication where we still use warfarin. Okay, 2 studies. A study called the RAPS, which is well over 10 years old, and then something called TRAPS, which is close to 10 years old, which is triple positive, where they have all 3. It shows these people have less thrombosis recurrence with warfarin. So this is, sometimes you know the cause and you don't have to get this. And the other bugaboo here is to really say you have this syndrome, you need to recheck the antibodies in 3 months, and they still need to be positive, because sometimes they're transient, especially with infections. Sometimes they could go cause false positive low titers. but they need to be treated with warfarin. So the point is here, in patients with idiopathic thrombosis, you need to think of this and check for it. And these patients need lifelong anticoagulation with warfarin. That's it.